to remove a small circle of bone from the skull. This was something that the ancient Egyptians did uh, 2,000-3,000 years back to try and relieve intracranial pressure. And the same technique was used to try and obtain a core of tissue from bone to evaluate hemopoiesis. It was first done in 1958, and the other alternative to examining bone marrow by histology was to prepare clot preparations of the aspirate. Now, when you look at all of these implements that were used to trephine, they look like something out of a torture chamber. We have progressed quite significantly currently, and we've got really, really good needles, which allow us to get really nice cores of tissue. Where do we get bone marrow biopsies from? The most common site is the posterior superior iliac spine, followed by the anterior superior iliac spine. In the pediatric age group, sometimes the tibia is targeted, sometimes the vertebra. Sternal biopsies used to be done in the past historically, but because of the significant risk of cardiac mortality due to cardiac puncture, by and large, nobody does sternal punctures anymore. Size does matter in terms of bone marrow biopsies, and we would really like to see biopsies that are at least 2 centimeters, if not 3 centimeters in length. Statistically, there was a study done at Imperial sometime in the 90s, which showed that a biopsy that was 1.6 centimeters in length was adequate for diagnostic purposes. Now, these pictures show you biopsies that are quite small and not particularly useful for diagnostic purposes. These, ranging from a little less than 2 centimeters in size, are interpretable, and you can certainly give a reasonable diagnosis on this. And these at the bottom are really nice biopsies, which we would all like to see, but don't see quite often. Now, why does the length of the biopsy matter? It is important because if you just look at this particular section, can you see my arrow?
So it's not clearly visible. Now it is.
Now you can see my arrow, right?
Yes, yes, sir.
Perfect. So if you look at this length of bone marrow biopsy, if the biopsy were to stop over here, it would have missed this lymphoid aggregate. So we would have missed it. Yeah.
Sir, it would be better if you can switch to laser pointer. This white is actually mixing with the background.
Sure. Give me one sec. Just remind me. How do I get a laser pointer? I go to that.
A left click on the screen, sir. Get you.
Yeah, pointer options, I got it. Perfect. Can everybody see this now?
So, yes, sir, this
Okay.
one's.
So if the biopsy were to end at this particular trabeculae, we would have missed this lymphoid aggregate over here, and we would have missed a diagnosis. So the longer the biopsy, the easier it is to pick up focal pathology within the bone marrow. Okay, how do we fix the biopsy? The most common fixative that we would use is neutral buffered formalin, and the optimal time for fixation is 18 to 24 hours. We usually would prefer that the biopsy is not fixed for longer than that because protein linkage tends to be very, very strong and impacts immunohistochemistry and molecular testing subsequently. There are a lot of other solutions that were historically used or are still used, especially in America. a lot of commercial fixatives are used which allow very, very rapid fixation and decalcification. But by and large, most of the world would use neutral buffered formalin. Following fixation, we need to decalcify the bone so that we can cut sections. And for that, there are two main agents that are used. One are agents that chelate the calcium from the bone, and the second is acids which replace the calcium. The preferred methodology for bone marrow biopsy decalcification is to use EDTA, and it takes about 48 hours at room temperature. If you have access to the bone station, you can optimize it to decalcify in anything between 12 hours and 24 hours. So that's a significant reduction in processing time. Formic acid is still used in some parts of the world, especially in America. All of us have moved away from using nitric acid because it just prevents the biopsy from being used for anything else. There are combined fixatives and decalcifying agents available. So acetic acid zinc formaldehyde, also known as the AZF fixative, allows you to fix and decalcify biopsies within 18 hours. And then there are, of course, multiple commercial preparations which try and do it in slightly smaller times. Microwave and ultrasound assisted decalcification has been used. It's used in individual institutes, but it's not very, very common. And I've just put these two pictures up to show you that there are differences in morphology when you use different fixatives and chelating agents. So for example, if you're using EDTA, even though it takes a little longer, the morphology is really, really spectacular. You're able to identify various cell types, nuclear membrane irregularities, chromatin differences, very, very well. When you try and shorten the processing time by saying using combined fixatives like AZF, morphology is still good, but it's associated with certain changes. Cells tend to be a little more hypochromatic. Nuclear chromatin is not, as crisp. So it just depends on what you're used to interpreting eventually. Now, even after decalcification, standard processing, you may get calcium within some parts of the bone, and you may need to resort to surface decalcification. And this is what you would see when there's remnant calcium. So this is a surface decal section, and you can see that at the edges of the biopsy, you've got pink undecalcified, sorry, completely decalcified bone. And here you've got a blotch of calcium in the center, which is a lot more purple. And this is after surface decal. So before surface decal, it would have been really intense, and there would have been a lot of scoring and chatter artifacts in the section. Currently, bone marrow biopsies are embedded in paraffin. Okay, nobody embeds them in plastic. This was reasonably common in the 70s and 80s, but nobody does it anymore. The most important bit after all of that is the sections, how you cut the sections. And if you get a section like this, it is impossible to interpret anything. It's like a piece of meat, and that's really no good. So the standard recommendation for cutting bone marrow biopsies is that for the H&E, we would like our sections to be between 1.5 and 2 microns thick, and we would like 3 micron thick sections for special stains and immunohistochemistry. And I'm not going to go into how you achieve those sections. So that's a matter for another talk. How do you determine quickly whether a bone marrow section is of adequate quality to interpret or not? You just simply need to pick up the slide and look at it against a white background. So if you look at this picture, they're both the same biopsy. They're just upside down. The one on the left, this one, is darker. You can see the red of the blood clot at the edge, and you can see that the substance of the marrow is an intense purple. Just looking at it, you would realize that this is going to be a really, really thick section and would be very, very difficult to interpret microscopically. The same biopsy has been cut again thinly. You can see that there's less intense red with the blood clot, and the substance of the marrow is now a lighter purple. So this color intensity tells you immediately that a section is of adequate quality for interpretation. If you can't do it by just looking at the slide with your eyes, you can look under the microscope, and if you see dense purple, pink like this, there's no point in going on high power. This is a completely useless section. Most of the problems that our technical colleagues have with cutting bone marrows relates to the rapidity with which they pick pick the sections up from the water bath. So you have to remember that the bone marrow, unlike other tissues that are being cut, the bits that we want to see are, how would you say, entrapped between bone. So you have to give the sections adequate time to float in a water bath where the temperature melts the wax and allows the tissue to spread completely. So if you look at the picture, the top left picture, this was what we got before. And this is a very typical example of what you would get in routine practice because people are trying to cut thousands of blocks on a daily basis. And you can immediately see that the fat is the adipose tissue is supposed to be round. But as you go towards the bone, you can see that the fat cells are not round, they're becoming angulated. You're very easily able to see the membranes in between the cells. And you can see them as slit-like spaces. And this is associated with a lot of nuclear overlapping. And this is simply because the section, even though it is thin, has not been spread adequately. And when you get it spread adequately, you can see it's the same section, a different version of it. And you can see how well the fat has spread. And suddenly you have no nuclear overlapping and you can see the cells very, very nicely. The same things illustrated in the section below. You can see how much nuclear overlapping there is. You can't even make out what the large cells are like. But when you get it cut properly and spread properly, you can immediately make out the megaloblastic dyserythropoiesis and the nucleoli, which you couldn't see previously. So these are things that you as pathologists have to give feedback to the laboratory technicians to say, look here, you need to leave it for another 30 seconds or a minute on the water bath, and then pick up the section, and you'll get really, really good sections to look at. Now, there is something while we want thin sections, sometimes in the attempt to provide thin sections, they cut them really, really thin. And you have to remember that there has to be adequate tissue on the slide for the stains to uptake. So on the left-hand side, you've got a thin section that's decent, that's interpretable. On the right, you've got a really, really super thin section, and you can see how stains are not taking. You can't even see the erosion properly. So too thin is not good for diagnostic purposes. Now, most of us in the UK have started using digital to report, and it's really, really nice. It makes a lot of difference. And this is an example of what bone marrow sections would look like when you see them on a screen. And one of the advantages is the ability to look at the entire biopsy at really, really low power, something that was a little difficult when using a microscope. So when you look at this picture, you can see immediately that the left-hand section, and this is the initial section, and this is the right-hand one is the 15th cut from the same biopsy. You can see that the left-hand section is intense, is dark. It's quite dark. while the left-hand one is light. So you would automatically look at the lighter section because you would be able to see morphology much better. Now, I'll just show you what happens when you zoom digitally on these kind of biopsies. So this is 0.5x. You can see the entire biopsy that's available to you for evaluation. And immediately at this thing, magnification, you can make out that there are lymphoid aggregates. There are these dark blue collections of cells distributed within various fragments. So immediately you get the impression that you're likely to be dealing with some kind of a lymphoproliferative process. Then as you go higher, you see them better. This is 2x, 10x. You can see a very, very nice lymphoid aggregate over there. 20x, cell morphology is very good. 40x, you can see the megakaryocytes very well. You can see the eosinophil granules, and you can make out the morphology of the lymphocytes. So again, we've got quite a heterogeneous population of lymphocytes there. And this is 60x, where you can see the beautiful lucent rings around the erythroid cells. So most of us are going to go down this route at some point or the other. And it works. What stains do we use? The most common stain is the H&E stain. That's what we use for routine diagnostics. The Giemsa stain was particularly helpful for bone marrow biopsies, largely because it allowed you to identify different granule types and different staining patterns. So for example, that's a very, very nice erythroid colony, and you can make out the eosinophil granules of the eosinophils and their precursors. But most of this has now been taken up by immunohistochemistry, where we have antibodies available for almost every cell or lineage type within the bone marrow, and even at sublineage level now. So for example, for erythropoiesis, we have a whole series of antibodies like leucophorins, hemoglobin A. For myelopoiesis, we'd end up using myeloperoxidase, CD15. For megakaryocytes, we'd use CD61 and CD42. For macrophages and monocytes, you have CD68 and CD14. For stem cells, you've got quite a large repertoire, 34, 117, HLA-DR, CD56 and CD123 pick up different subsets of stem cells. Hematogones are quite easily identified by TDT. For lymphocytes, you'd use a huge number of antibodies, but 20 and 3 are good examples. For B and T cells, for plasma cells, MUM1 is a really, really good antibody. And of course, you'd use light chains, kappa and lambda. And mast cells are very easily identified using mast cell tryptase. So we end up doing a lot of immunohistochemistry on bone marrows to try and dissect the various lineages that are present. Okay, so now that we've covered processing, let's move to interpretation. So the first thing that you're going to see in a bone marrow biopsy at low power is that it seems to be composed of multiple different tissue types. So just think about it as the needle goes into the bone. So there's usually a small amount of periosteal dense collagenous connective tissue at the end of the biopsy, sometimes associated with blood vessels. And this is the usual in most adult patients. If you're dealing with children or the really elderly, the collagen is usually replaced by a cartilaginous cap. So you'll see cartilage over here rather than collagen. Immediately beneath the periosteal collagen, you've got a dense layer of bone, which is the cortical bone. Okay. And this will show you your Haversian canals and all of the things that you expect with dense bone. And as you get into the medulla of the bone, the cortical bone breaks up to start forming trabeculae of lamellar bone. And you can see that very well as you go deeper into the medulla. You can see these very, very, very nice trabeculae. And the bone marrow is present in between these trabeculae. The space in between two trabeculae is known as the intertrabecular space. And I just want you to keep this in mind. So just look at this. You've got a bone trabeculae at one end and you've got a bone trabeculae at the other end. And you've got marrow in between. And we'll come to this in a little while. One of the first things that we do when we're trying to assess hemopoiesis is we try to determine what the cellularity is, because changes in cellularity are directly proportional to disease processes. So in hypoplastic processes, the bone marrow tends to be hypocellular, and in proliferative processes, the bone marrow tends to be hypercellular. But to try and determine whether something is hypo or hypercellular, you need to know what is normal for the age of the patient. And cellularity varies depending on the age of the patient. Now, a simple formula is cellularity is 100 minus the age of the patient. And this formula comes with caveats. It works well in the normal adult range. Okay. So say, for example, you have a bone marrow biopsy from somebody who is 40 years old. 100 minus 40 is 60%. So you would expect hemopoietic cellularity to be about 60%. So 40% of the intertrabecular space should have fat and 60% should have hemopoietic cells. Okay. This works well in the adult group. Children, newborns, by and large, tend to have cellularity more than 80%. It's almost 100% at birth and gradually reduces. So by 20, this formula starts working. As you cross 70, this formula stops working because cellularity tends to remain constant at about 20 to 30% as you cross 70. Okay, so it has caveats, but by and large, it's a useful indicator of what normal cellularity should be for any given age. Now, most people say, oh my God, the bone marrow, it's so complex to interpret. There's so many cells over there, we have no clue what's happening. And it's such a disorganized organ. Look at the liver, for example. It's so simple to interpret. There are only hepatocytes over there and some biliary tracts. But that's not the case. The bone marrow, despite having so many cells, is a highly organized organ, and you just need to understand how to interpret it. And for that, you need to know how normal hemopoiesis is distributed within the bone marrow. Okay, so I'm going to need you to concentrate on our concept of the intertrabecular space. So we've got two bone trabeculae in this picture. You've got one on this side and you've got one on the other side, and this is your intertrabecular space. Now, if I was to divide it, oops, what happened to my anime? If I was to divide it, okay, you've got two exact halves, okay? You've got bone and hemopoiesis on this side, and you've got bone and hemopoiesis on this side. And for the next couple of slides, we are just going to concentrate on what happens in this half of the intertrabecular space. And I'm going to show you how bone marrow is organized. So this is a picture of that half of the intertrabecular space. And if we look at the third of the bone marrow immediately adjacent to the bone, you can see that the predominant cell type over here is mononuclear. Okay, they're medium to large cells, and all of them seem to have round nuclei, round or ovoid nuclei. And the chromatin pattern is open, so the cells look light. So this is where your immature myeloid cells are. And you can see that some of these immature myeloid cells are starting to produce granules. These are your promyelocytes. If we look at the middle third of this half of the intertrabecular space, you can see that the picture suddenly changes. It doesn't look light anymore. You're seeing a lot of dark nuclei. And this is where your erythroid colonies are located. So the middle half is where erythropoiesis happens. And if you look at the inner third, you can see that you're suddenly starting to see megakaryocytes. So that's where your megakaryocytes live. And when you look at the picture again, you can see that neutrophils are distributed in the central two-thirds of this intertrabecular space. So if you remember this, that your immature myeloid cells are normally located near the endosteal surface, your erythropoiesis is located towards the middle, and megakaryocytes are largely seen in the middle of the intertrabecular space. You know immediately where to look for different cell lineages. Now, whenever there are expansions of these cell lineages, they start occupying different areas of the intertrabecular space, and that tells you that you're dealing with a pathologic process. Okay, so we come to the first question in my talk, and can I have one of the students volunteering to deal with this? Or maybe we'll have two students and we'll split the questions. Which two students want to do it?
So, if we can just call out the names, they'll just pitch in and speak for it.
I tell you, Parul, why don't you select because I can't see the
Yeah.
names.
Hello. Okay, Dr. Rifty and Dr. Rani, please pitch in for this one.
Okay, Dr. Revti, can you describe what you're seeing?
Dr. Rani, Dr. Charita. I'd like students to unmute themselves, please. Dr. Khushi, Dr. Sumiti. Dr. Prashant.
Sir, so this is a macrophage. Like basically, this is a section of a bone marrow
Okay,
showing the arrow is pointing towards the macrophage.
okay, forget the arrow.
Okay.
What is around the arrow? What's there in the picture? Bone
Sir,
marrow is correct, but
erythroid precursors.
perfect. So these cells over here are erythroid precursors, and this is an erythroid colony. Excellent.
Yeah.
And you have answered my question that the white arrow is showing a macrophage. Fantastic. So why don't we move to the third question on this list? Which two stains would highlight the structure and with what colors? So what is the structure that I'm talking about? Okay, so just concentrate on this macrophage, okay? Is there anything within the cytoplasm?
Vacuolations.
Very good. And apart from that, what is the color of the cytoplasm?
Clear.
Right, and in between the clear, where my pointer is?
Reticulin. I mean, like fiber.
No, within the cytoplasm.
Iron stores. Ferritin.
Iron stores, true, but what is the color that you're seeing over here?
It's brown.
Brown.
Yeah, it's brown, right? Okay.
Orthochromic.
So what, if you're talking about iron stores, we expect it to be hemosiderin, right?
Yes,
Yeah.
sir.
So it should be golden brown. And now can you see that it looks a little golden brown compared to the rest of the marrow?
Yes, sir.
Maybe. Okay. So what stains would you use to identify hemosiderin or iron?
Paul's
Pearl.
stain.
Pearl stain, very good. That's one. Anything else? What was the other stain that I mentioned that was used quite frequently for bone marrow biopsies? Something that stains everything purple. Guys, what stain do you use for blood films?
Romanowski stain.
Fantastic. Which Romanowski stain?
Leishman. Jesus.
You use Leishman or Giemsa?
Leishman
Did I
stain.
not? You use Leishman stains. Perfect. So if you were to do a Leishman stain over here, what color would you see the iron as? No idea. Okay, it would stain olive green. I'll ask you a simpler question. If you did the pearl stain, what color would we expect the iron to be?
Green.
Sorry? What color does iron stain on a pearls?
Bluish green.
Bluish green. Okay, perfect. Very good. Now, what factors must you consider when evaluating the contents of iron on a biopsy? Any idea? It's got to do with decalcification. Any thoughts? Anybody? I'm not seeing any suggestions in the chat either. The important thing to remember is iron, it's a metal, right? If you're going to be using acids, it will dissolve the iron. So even if there is iron in the biopsy, acid decalcification will show you a negative pearl stain. So be very, very, very careful when you're trying to interpret or look for iron, that you know how the biopsy was decalcified. Okay? Which is one of the reasons why we've gone down the EDTA route. Okay, let's move on. Erythroid series. How does it look like on histology? I think most of you all will be familiar with how erythropoiesis looks on bone marrow aspirates and in peripheral blood film, right? So we've got an entire lineage of cells from the basophilic erythroblast down to the red blood cell. Now, the erythroid series in the bone marrow is present as colonies, okay? And they look blue in color. They're usually seen in the central regions of the intertrabecular space. They're usually associated with an iron-laden macrophage, and I'll show you all of that. So just look at the cartoon over here. And you can see that the blue colored cell here in the center is your macrophage, which contains iron. And immediately around this macrophage, you've got all of your early erythroid precursors. And basically what the macrophage does is it feeds these cells iron to allow them to produce hemoglobin. And these immature erythroid cells then start maturing. So you start getting normoblasts, and then you get reticulocytes, and then you get RBCs as you move away from the macrophage. So now if you look at this picture that I'm showing you, this is an erythroid colony, okay? And you can see the hemosiderin granules in the center. Can you see that over here? There's a granule here. There's a very nice granule here. There's a bit there. There's some more there. So these are the dendritic processes of the macrophage going in between the erythroid cells. And in the center, you can see your large erythroid cells, which are your precursors. And then as you move to the periphery, you can see that they're becoming smaller in size. The nuclei are becoming more hyperchromatic, and so on and so forth. So that's how maturation occurs. And this is a nice picture to show you the different kinds of nuclear chromatin patterns that you get in different erythroid cells. So the one with the big arrow is a proerythroblast. You can see that it's a very large cell. It does not have hemoglobin in the cytoplasm. The nucleus has got a good cell membrane. The chromatin is open, and you've got a big nucleus, nucleolus in the center. As they mature, you can see that chromatin is becoming more dense. You can see that very well over here, darker, and the nuclei become smaller, and these are your basophilic or normoblasts. And then the chromatin condenses further to form what you would expect to see in a reticulocyte. And finally, this nucleus would be extruded and you would have a RBC without a nucleus. And just to show you that erythroid cells have very, very hyperchromatic inky nuclei as they mature, which is what allows you to identify them very, very easily on sections. If you have to resort to immunohistochemistry, you can use any of the glycophorins, glycophorin A, glycophorin C, work really well. The only problem is that the glycophorins end up staining red blood cells as well, not only the nucleated erythroid precursors. So using them diagnostically is a little messy. If you have access to alpha hemoglobin, that stains only the erythroid precursors. So that's a very, very nice stain to interpret. Okay, let's move on to case 2. And again, we're going to need some students, 2 students.
Dr. Prashant? Dr. Sumiti, Dr. Prashant?
Okay. Does somebody want to identify the cells highlighted by the white arrows? Do you want to describe them for me? So we've got 2 cells over here marked by white arrows.
Anyone can pitch in?
Myeloid precursors, sir.
Myeloid precursors. Do you want to describe them?
Okay, these cells are round to oval
Okay.
with prominent cell borders having prominent nucleoli.
Okay. They don't have prominent cell borders, right? You can't really make out their boundaries. They have prominent nuclear membranes, I'll give you.
Yeah, prominent nuclear membranes, yeah.
Yeah. Okay, what would you say in terms of cell size? So that's a lymphocyte over there where my laser pointer is. So
They're
compared to that
large.
lymphocyte, they're large cells. Very good. So we've got large cells. They've got cytoplasm. You can't make out where the cytoplasm ends. But the characteristic feature is that they've got large nuclei with a crisp nuclear membrane, open chromatin, and one or multiple nucleoli. Yeah?
Yes, sir.
And you say that they're immature myeloid precursors. Would you care to be a little more specific?
Myeloblast.
Excellent. So if you were looking at this in the aspirate, you would identify them as myeloblasts very, very easily. Punched out nuclei, large nucleus, high NC ratio. Yeah,
Yes,
very
sir.
good. Okay, now let's move to this cell highlighted by the blue arrow, which is this one. Do you want to describe it for me? I think there are at least 5 or 6 students. This is
Okay,
not really so difficult.
okay, this cell is large with high
Okay.
NC ratio, having a prominent nuclear membrane with open chromatin and a prominent nucleoli.
Fantastic. Something about the cytoplasm. Does it look the same as the myeloblasts, or is there something a little different about the cytoplasm?
Unable to appreciate, sir.
Okay.
Cytoplasm is eosinophilic, shows it is eosinophilic, possibly granules.
Very good. So, if you just notice, it's much pinker. The intensity of pink is higher. And you're right, they're pink granules, and this is what you would call a promyelocyte. Okay,
Yes, sir.
perfect. Very good. Now let's move to this picture on the right-hand side. So, there are 2 cells marked with white arrows. There's one over here, and there's one over here. What do these look like?
Band forms.
Very good. So they've got U-shaped nuclei. Yeah, almost horseshoe shaped. They've got a cleft in the center, and they are band forms or metamyelocytes, however you want to call them. And then, of course, you've got cells marked with green arrows. What do you think they are?
Neutrophils, segmented
Neutrophils.
neutrophils.
Segmented neutrophils. Perfect. So you can see that between these two pictures, the differences between the cell types and that they are appreciable on histology. So I'll quickly run through the myeloid series. You've got all of these differentiation types that you can see on the right-hand side, and you can see all of them in the marrow on sections. Now, the myelopoiesis is largely seen around the endosteal part of the bone that we've all agreed, and it can also be seen around arteries within the substance of the marrow. I don't have a picture of that, but I'll quickly go through the cell types again for you. So I think everybody should be able to recognize myeloblasts. They look exactly the same as in aspirates. Large cells, high NC ratio, crisp nuclear membrane, and open chromatin, and prominent nucleoli. Promyelocytes, you can see the arrows over here. Again, large cells, usually single nucleolus, and lots of cytoplasmic granules. This is a higher power magnification to show you what promyelocytes look like. It was a case of myeloid maturation arrest at promyelocyte stage, but it shows the morphology very, very well. And then you've got myelocytes, so you can see that over here. The cells are smaller, the nuclear chromatin is denser, the nucleolus is not apparent, and some of them have granules. MPO is excellent at highlighting the immature myeloid precursors. So the mononuclear myeloid precursors, MPO picks them up very strongly. And if you look at this picture on the left-hand side, you can see this bone trabecula and you can see the scuff of myeloid cells around the bone trabecula. And as you go into the marrow, you can see that there's very, very little in the way of MPO positivity. And the top right picture, you can see this blood vessel in the central part of the bone marrow, and you can see a cuff of immature myeloid cells within it. So this is this is normal hemopoiesis. And if we look at the differentiated myeloid cells, you've got your metamyelocyte, so just the beginning of an indent over there. You've got your band form, very nice horseshoe shaped, and you've got neutrophils, which are completely segmented. CD15 is a very, very good stain to pick up your differentiated myeloid precursors. It picks up all myeloid cells, but the staining pattern doesn't allow you to differentiate immature from differentiated very easily as compared to MPO. So if you look at the MPO on this side, you can see that it's picking up the immature precursors very, very well. Here you can see very little in the interstitium, while the CD15 picks up all of your neutrophils very, very well within the interstitium. And again, the bottom pictures, that's MPO, showing you intense cytoplasmic positivity, round nucleus. And you can see the CD15 on the other hand is a very speckled light positivity in neutrophils. Eosinophils are very easy to identify. They've got very, very prominent eosinophil granules. The immature stages contain a mononuclear nucleus. The differentiated forms have bilobe nuclei. Basophil and their precursors are difficult to identify on histologic sections for two reasons. One, they're really small in number, and two, the basophil granules are actually soluble in water, and formalin contains water. So that generally dissolves the granules and makes it very, very difficult to stain even on Giemsa. If you want to identify basophils in a marrow for whatever reason, there are specific antibodies for basophils which work well on histologic sections, 2D7, BB1, and basophils also highlight with CD123. So that's that. The ME ratio is something that all of us would like to know. It gives you proportions of lineages. The normal ME ratio is 3 to 4 myeloid cells for every erythroid cell. It varies between 2 to 4.5, and post-birth it's reversed, so you have significantly more erythropoiesis in that age group than you have in adults. On histologic section, CD15 is a very, very good stain to enumerate the ME ratio. You can see that the erythropoiesis and megakaryocytes in this picture are blue, and myelopoiesis comes out as brown, so it becomes easy to calculate proportions. Okay, move on to case 3. Right, what is the cell in the center with the white arrow? Now, this is a very easy question. So all of the students who have not said anything can now say something.
It's a megakaryocyte.
Excellent. Very good. If you had to use immunohistochemistry to identify megakaryocytes, what antibodies would you use? Any idea?
CD61 and CD42.
Fantastic. 42. Very good. Right. Now, there is a small white arrow towards the bottom of this picture. Can you see that over here? Can anybody tell me what is happening over here? I just want you to describe what you're seeing. Kushi, you want to say what you wanted to say? Okay, somebody, Kushi, has said in the chat that it's a
Actually the platelets are released from the cytoplasm of the megakaryocyte.
Okay, but what are you seeing over here? What is actually happening? Okay, so what is this white colored structure or space?
Lipid fats.
Do you think it looks like fat? Okay, this is
Sinusoid.
fat, right? Sinusoid, very good. There are RBCs and immature myeloid cells in this space, so it has to be a sinusoid. Very good. What is this cell?
It's a megakaryocyte.
Megakaryocyte.
Very good. So megakaryocyte is sitting very closely opposed to the sinusoid. And what do you think it's trying to do?
It is undergoing cytoplasmic fragmentation to give rise to platelets.
Yeah, how does that actually happen? Has anybody ever considered how the megakaryocyte with such a big nucleus and the platelets that you actually see in peripheral blood, which have no nucleus and are so tiny, how does it actually happen? Look at this top megakaryocyte over here. Can you see this one? What's happening to the edge of that megakaryocyte?
Fragmentation.
No, forget the fragmentation. What are you actually seeing? Is it a smooth boundary?
No, it is looks more
It's
serrated.
spiky.
Yes,
It's
that's
serrated and spiky, isn't it?
yes, sir.
So basically what happens is megakaryocytes migrate through the marrow to reach sinusoids, right?
Yes, sir.
And then they push their cytoplasm against the endothelial cells, because remember, there is only a single strand of collagen in between the endothelial cells or sinusoids and the interstitium of the bone marrow. And what they do is they push the cytoplasm in between the junctions of the endothelial cells. Okay. And what is in the sinusoid? There's blood, right? blood is flowing with force. So what happens is those cytoplasmic projections get sheared off, and that's how you get platelets in blood. And this picture tells you that story so well. Everybody understood?
Yes, sir.
Yes, sir.
Fantastic. So let's talk about megakaryocytes. They're usually located in the central regions and perisinusoidal areas of the bone marrow. They're big cells. They have a big nucleus, which is usually lobate, and the lobes are joined by variably thin strands of chromatin. And we've already talked about cytoplasmic fraying and becoming platelets. And eventually, after all of the cytoplasm has been frayed, all you end up is getting is a small pycnotic nucleus, which I'll show you a little later. Okay. Now, megakaryocyte have very variable morphology. As you can see from this collage of pictures, you can see that the nucleus can be small and mononuclear and hyperlobated, to this kidney-shaped thingy, which is not particularly lobulated, to things that are trying to form lobules, to multiple weird combinations in between, to very lobulated forms like we're seeing here, and to polynuclear forms. And this is one of the reasons why trying to define megakaryocyte dysplasia is difficult. And we're not going to go there in this particular talk, but I'll try and explain to you why you see such a remarkable difference in megakaryocyte morphology in any given biopsy. And all of it is normal. Before we go there, I just want to show you the senescent megakaryocyte. So after all of the cytoplasm has disappeared, you get this kind of very, very hyperchromatic large nucleus floating within the marrow interstitium. And eventually this nucleus will break up and the nuclear debris will go and be phagocytosed by the macrophages within the marrow. Okay, let's talk about why megakaryocyte morphology is so variable. The megakaryocyte is one of the largest cells in the body. Its average size is 150 to 180 microns. Okay. Now think about it as a football. Okay. Each of our sections is 3 microns. So you should be able to get 60 sections before you cut through a megakaryocyte, right? So what happens if I cut over there at that edge of the megakaryocyte? You're going to see something like this, right? You're going to see a small bit of nucleus in the center, and you're going to see a small megakaryocyte over there, cytoplasm. If this level of the section is there, that's what you're going to see, slightly lobulated, with another nucleus over there, which is trying to lobulate. You go deeper, the cell becomes bigger, you get more lobulation, you get more nuclei, you cut it over there, it looks like that. And you cut it over there, you only get pink cytoplasm. And that's why megakaryocyte morphology is so variable. This is what CD61 looks like. It stains the cytoplasm intensely, and you can see that megakaryocytes are distributed quite diffusely through the interstitium. And this is what platelets look like on CD61 immunohistochemistry. Something that you often see in megakaryocytes is the phenomenon of emperipolysis. Okay, and basically what you will see is that you've got megakaryocyte cytoplasm. It seems to have lots of other hemopoietic cells which are present within the cytoplasm. And this process is known as emperipolysis, and it happens because megakaryocytes have to move towards sinusoids to release their platelets. And they have to move through what is this entire highly crowded bazaar of hemopoietic cells. And it's not like the hemopoietic cells make way for it. So what the megakaryocyte does is it pushes its cytoplasm around these individual cells and forms tunnels. And if you cut the megakaryocyte right on sections, you can actually see the tunnels with individual hemopoietic cells in them. So effectively the megakaryocyte passes through hemopoietic cells on its journey towards the sinusoid. And this is pretty well seen here on CD61, where you can see these lots of neutrophils within the megakaryocyte cytoplasm. Now, this phenomenon is particularly common after viral infections. And I just wanted to show you this. This is something that I saw this week. And it was a bone marrow, a hypercellular bone marrow with megakaryocytes. And you can see the degree of emperipolesis. It's so florid. You've got 3 megakaryocytes here. All of them have got these things, hemopoietic cells within them. And the reason for that is quite obvious. When I stained the marrow for Epstein-Barr virus, you can see that there's loads of EBV positive lymphocytes within this marrow. This marrow was actually involved by angioimmunoblastic T-cell lymphoma, which explains everything. But again, viral infections and emperipolesis go hand in hand. Moving on to monocytes and dendritic macrophages. There are a huge number of macrophages within the bone marrow. And the vast majority of them are dendritic macrophages. And the dendrites of the macrophages are well seen on. Sorry, are the slides not moving? Is
So they are.
everybody?
They are.
They are,
sir.
they are, right. Okay. And the dendritic processes are very well seen on CD68 staining. You can see that really nicely here on this higher power magnification where the processes go in between hemopoietic cells. Monocytes are these smaller mononuclear cells which show cytoplasmic granulation. And CD14 highlights these monocytic cells very, very well on histology. Plasmacytoid dendritic cells are usually highlighted by CD123. Remember, CD123 also highlights other things like basophils and blasts. And the function of these phagocytes is to phagocytose or mop up all the debris that is produced by cell death or cell degeneration within the marrow, including megakaryocyte nuclei. And you can see that very, very well over here. You've got all of these large macrophages which contain both proteinaceous material as well as nuclear debris within them. The other function of macrophages is to store iron, and you can see hemosiderin as a brown pigment, golden brown pigment in the central picture. And of course, it stains blue, bluish green on pearls, and it stains an olive green on Giemsa. Plasma cells account for about 2% of bone marrow cells. They're usually singly distributed or are usually seen around capillaries. And this is a very, very nice example of a capillary with plasma cells around it. And it's got to do with them producing antibody and releasing it. Another example on Giemsa. They are polyclonal. The kappa lambda ratio is usually 3:1. And the top picture is a nice example of a double color in situ hybridization for light chains where kappa is brown and lambda is red. So you can see that the kappa cells predominate the lambda cells. There are lots of lymphocytes in the bone marrow, about 10 to 15% of TNC, and most of them are T cells. So the B to T ratio is 1 B cell for 4 or a little more than 4 T lymphocytes. And most of them are cytotoxic T cells which express CD8. There are few helper T cells within the marrow. CD4 CD8 ratio is usually 1:3:4. NK cells are easily identified using CD56 staining. There are small numbers of them scattered within the marrow, and CD57 would highlight activated T cells. Within the normal marrow, we can sometimes see lymphoid aggregates. And there are 3 types of lymphoid aggregates. Those that have germinal centers, those without germinal centers, and micronodules, which are usually highlighted by immunohistochemistry. The commonest are lymphoid aggregates without germinal centers, and this is a good example of that. You can see this nodule of lymphocytes. They're usually small lymphocytes admixed with a few medium-sized cells. And when you do immunohistochemistry, you realize they're usually T-cell rich with few B cells within them. And these are usually seen as a reactive phenomenon or are seen as a consequence of autoimmune disease. And when you examine bone marrow biopsies from normal elderly females, you always see them. Okay. The micronodules are usually seen on immunohistochemistry. They are composed of CD8 positive T cells. They're usually collections of anywhere between 4 and 10 lymphocytes, and they're distributed throughout the marrow. And they usually mean that the marrow is responding to some kind of systemic insult, usually a viral infection. Very rarely you will see lymphoid follicles with germinal centers within them. And when you see these germinal centers, they invariably BCL2 negative, meaning that they are reactive. And this is often seen in patients with rampant autoimmune disease. Mast cells, they're present. They're usually present around the endosteal surfaces, around blood vessels. They're not very well identified on H&E, but if you do a GIMSA, they will pick up metachromatic staining and the granules are purple in color. If you want to identify them, mast cell tryptase works beautifully well, which is this picture over here. And CD117 highlights them very well with an intense brown stain. And then finally, we've got stem cells, which are your blasts. You, by and large, find it difficult to identify them on H&E unless you're looking very, very carefully. So we usually resort to immunohistochemistry to make our lives easier. CD34 is a good stain for hemopoietic blasts, and in the normal marrow, you'll usually find one cell in every 4 to 5 high-var peels. CD117 is also a good stem cell marker, but just remember it's not specific. Not only does it stain stem cells, it also stains early erythroid precursors, early myeloid precursors, plasma cells, and mast cells. The good thing is that each of these cell types has different staining patterns. So for example, the proerythroblasts, these cells over here, are large. They've got a very crisp membrane staining, and you often see Golgi staining as well. This particular one, you can see the Golgi. Mast cells, on the other hand, are intensely brown like these. And this is your blast, which is medium-sized and ovoid. Hematogones, another type of lymphoid stem cell or immature B cell, usually numerous in pediatric bone marrow biopsies. Numbers significantly reduce as you go into adulthood. They usually identified distributed singly, and they TDT positive, they're 10 positive, they express some B cell markers, they're usually CD20 negative. PAX5 is quite helpful in identifying them if you've got access to PAX5. So TDT PAX5 is a good marker for hematogones. So we've covered most of the cell types in the bone marrow. Let's quickly move on to the stroma. The most common stromal component is fat, all of these adipocytes, and fat increases with age. So you have to remember that as people age, immediately beneath the cortex of the iliac crest, fat accumulates. So ignore the first couple intertrabecular spaces when you're interpreting biopsies and don't use them for cellularity assessment. Otherwise, you'll always get hypercellular bone marrows. And then apart from the fat, the bone marrow interstitium also contains matrix. And there are different kinds of matrices. Matrix that you don't see, which is glycoprotein, which you start seeing in pathological conditions like gelatinous transformation. And you've got fibers. You've got two different kinds of fibers composed largely of the same thing. One of them we call reticulin fibers, the other we call collagen fibers. And reticulin fibers are identified using a silver stain, the Gomorius technique, and this is a picture showing you reticulin fibers. These are these black fibers which are going across the bone marrow, and you can see them over here around the wall of a sinusoid. So what are reticulin fibers? They're a type of collagen which arise from bone. So look at this top picture, the curved reddish brown structure over here is bone. And you can see that the end osteal surface of bone is frayed, and your reticulin fibers are rising from this and they go into the substance of the marrow. Okay, so look at the lower picture now, lower right, and you can see the same thing over there. You can see these fibers going in between individual hemopoietic cells, forming a meshwork, and they eventually go and wrap around the walls of capillaries and arterioles, and then they progress, and then they go and form the walls of sinusoids, which is seen over here, and then they go back and attach to the endosteal surface of bone on the other side. So it's like a complete scaffolding meshwork which spans from one intertrabecular space to the other. You know, for all of you in the audience, have you ever considered what the state of the bone marrow is like when you're able to aspirate it, right? When you put a needle into the bone, you pull it out, right? When it comes out, it's liquid. So my question is very simple. Have you ever thought of why bone marrow doesn't settle to the bottom of every bone when you stand? Because if it was liquid, it it should all pool to the bottom of bones, but we see it uniformly distributed across bones. And the reason for that is because you've got a reticulin meshwork which prevents the cells from falling. So this is a high power view to show you what reticulin fibers in the normal bone marrow would look like. So you can see that they're thin and they are short. They disappear after a period of time. You can't see the reticulin fiber going all the way across. And that is what tells you that the reticulin fiber pattern of the bone marrow is normal. There is no evidence of fibrosis. Reticulin fibers are also present around fat cells. That's how the fat cells stay in space and they don't squash the hemopoietic cells. They also form the walls of sinusoids. You can see that over here very nicely, and you can see how delicate this reticulin framework is. The other fiber that we identify is collagen. You have to remember that reticulin and collagen are both collagen. They're just different types of collagen. They stain with different stains and they're seen differently in different pathologic processes, which is why we make such a distinction. Collagen is normally not identified in the normal bone marrow interstitium. It is only present around blood vessels, and you can see that very, very well over here. So we would normally stain collagen with either Mason's trichrome or an MSP stain, which is Marshall's scarlet blue. And with the trichrome, we usually use a green counter stain, so the collagen appears green. And with the MSB, we use a blue counter stain, so it appears blue. And the fibers appear quite wriggly, okay? But there is no collagen in the interstitium in the normal marrow. The other stromal components are, of course, periosteal soft tissue, cartilage, I've already mentioned this, pediatric and elderly biopsies, cortical bone we have discussed with its Haversian system, and trabecular bone, which is composed of lamellar bone, completely different morphologic appearances. Then, of course, you have bone-related cells. You've got osteoclasts, which are multinucleate and are present in these lacunae. Yeah, look very, very different from megakaryocytes. And you've got osteoblasts, which look like this. They look quite plasmacytoid and have very, very good Golgi complexes because they're producing osteoid. And then, of course, the bone marrow contains blood vessels of various calibers. So you've got arterioles, which feed blood into the marrow. They become capillaries, and then the capillaries become sinusoids, and these become veins, and they look very, very different. So, case 4. What stain is this? Absolute silence.
Please unmute yourself. Dr. Ritika, Dr. Charita, Dr. Rani, anyone?
Sorry, did somebody say something?
So plasma cells.
No, I'm asking you what stain it is. Very good. Khushi says it's Gimsa, and so do several other people, so it must be Gimsa. Very good. I agree with all of you all. Somebody is saying Alcian blue. No, this is not Alcian blue. Okay. What cell is highlighted by the thin arrow, which is this one?
Mast cell?
Excellent. Very good. What cell is identified by the short thick arrow, which is this one? Come on, seriously, it's not so difficult. It's got eosinophilic orange, reddish orange granules. You can see one tiny little nucleus here, and you can see another tiny little nucleus over here. So it's got a bilobe nucleus.
Eosinophil.
And it is definitely not an RBC. Come on now, seriously, which self-respecting RBC is so big? That is an RBC. Eosinophil?
Yes, sir.
Very good. Excellent. What cells are identified by the red arrows? Very
Erythroid
good.
CV, sir.
Very good. Excellent. I think we're going to skip this last question. Okay. Let's look at what the bone marrow aspirate does for us and what the bone marrow biopsy does for us and what kinds of information we can get preferentially from each of these techniques. They are both complementary. There is nothing like one is better than the other. They both give us different information. Okay. With the aspirate, we are looking at cytologic detail. Okay. We are looking at granules. We're looking at cytoplasmic structures. We're also looking at nuclear details. Counts. We're able to do counts very, very effectively on the aspirate. We get a very accurate iron status because the aspirate has not been, how would you say, modified by the decalcifying process. It's just whatever is there in the body is there on the slide. And if you want to look for ring sideroblasts, this is the best way to look for ring sideroblasts because you simply can't do it on histologic sections. What does the biopsy give us? It gives us what the overall architecture is, what's happening where. It allows us to do fibrosis assessment. It identifies extraneous stuff within the marrow like amyloid, which is difficult to do on the aspirate. It allows you to look for stromal changes like gelatinous change, fat necrosis, so on and so forth. Bone pathology is very easily identified on the biopsy. We're able to do immunohistochemistry or in situ hybridization, which allows us to determine what cell types are where and what they're doing. Allows a very accurate characterization of metastatic and infiltrative processes, i.e. granulomas. You can do buck stains. You can find out what's happening. You can identify the site of primary origin for metastatic tumors. It's very effective in identifying focal pathology. So, small deposits of myeloma, when you have a micronodular myeloma, or focal lymphoid aggregates, or systemic mastocytosis. Okay. And it's really good for identifying or quantifying myeloma disease bulk. Okay. I'm going to spend a couple of minutes on fibrosis assessment because this is an important part of bone marrow biopsy interpretation. I'm going to be quick because I understand it's getting late in India. We identify reticulin. Fibrosis assessment is done using the assessment of reticulin fibers and collagen fibers. For reticulin fibers, we use the reticulin stain. If you can also identify collagen fibers on it if you do it well, and I'll show you how. The reticulin silver stain that is preferred is the Gomori's silver technique. The Gordon suite tends not to work so well. The first question you have to ask is, has the stain worked? Very easily answered. Look at the blood vessels. If you can see reticulin, if you can see fibers around the blood vessels, your stain has worked. Next question, where do you evaluate the stain? You look only in the hemopoietic areas, okay? Don't look around the bone. Make sure you're not evaluating lymphoid nodules because they will always have more reticulin fibers. You're not considering vessels, and you're not evaluating the vessels around the adipocytes. So you have to look within the interstitium. There is a grading system which has been approved by the WHO and is universally used. It's called the MF system or the WHO system, whatever you want to use. It is made up of 4 grades. 0 is normal, 1 is early reticulum fibrosis, 2 is reticulin and collagen fibrosis, and 3 is extensive fibrosis. And I'll show you what all of them look like. So the top left picture is grade 0. It's normal bone marrow. You can see individual reticulin fibers. They are truncating. They're short. You can't trace them. And they're definitely not crisscrossing each other. Grade 1, you can see reticulin fibers. They're more in number. They are more elongated. And they're crisscrossing. Okay. Grade 2, the fibers are becoming dense. They're almost contiguous. And they're forming meshworks. Okay. Thicker bundles. Grade 3, it's almost everywhere, very, very thick. And you can see that the reticulin, rather than being black, has started taking a orangish brown hue. And that's a good indicator that you've got collagen. Okay. You can do ancillary techniques on bone marrow biopsies. You can do fish, decalcification. The type of decalcification determines whether you can do fish or not. If you're using EDTA, yes, fish is 100% successful. If you're using acid-base fixatives, you're unlikely to get good results. Why do we need to do fish on biopsies? You sometimes have to do it when an aspirate is not sent for cytogenetics and you've got good going lesion on the biopsy. The aspirate may not necessarily contain malignant cells, so the biopsy is again used. Sometimes highly proliferative lesions, apoptose, and the aspirate may not be suitable for analysis because the nuclei have broken down. And of course, if you're trying to do retrospective analysis on a biopsy a couple of years later, when new probes become available, it is not possible on old aspirates, but you can do it on the biopsy. We can do PCR, tonality, NGS on biopsies. Again, dependent fixation. With EDTA, you've got good results. With AZF, you've got poor results. And these are some examples of the kind of molecular tests that we usually request in routine practice. This is just to show you what the impact of fixation and decalcification is on ancillary testing and how it works. So if you're using neutral buffered formaldehyde versus a acid containing fixative, you can see that with neutral buffered formalin, you can do immunohistochemistry, you can do fish, you can do molecular. If you're using an acid, you can do immunohistochemistry, but fish and molecular may be difficult. Same thing for decalcification, EDTA versus an acid. With EDTA, everything is possible. With acids, the specialized testing is usually not successful. This is what the standard bone marrow biopsy protocol is at our institute. We use neutral buffered formalin, 12 to 24 hours. We use EDTA and heated oscillator, anywhere between 24 and 48 hours, depending on what machine you're using. Routine processing is overnight. We embed in paraffin. H&E is cut at 2 microns, 3 levels. We do a pearls reticulin at source. And we generally ask the laboratory to have 15 unstained sections kept ready for immunohistochemistry. Thank you very much. I hope that was useful, and I will stop sharing.
Thank you so much, sir, for sharing your expertise with us. That was quite well explained. I'd like to invite Dr. Vijay. Sir, please share your insights on the topic.
Am I audible to you, sir?
Yeah.
Yeah. It's a wonderful exposition of slides of normal morphology of bone marrow, and especially the ISC. And for the beginners, it is very, very important to know what is normal, and only then you can appreciate the abnormal. I have just few comments that I want to add to whatever you have said, sir. One thing was that you told that a length of 1.6 centimeter would be considered adequate because there was a study done in your center. There is also a microscopic way to determine that how is it adequate or not. Because if you find 10 intertrabecular spaces, then you are sure that this biopsy is adequate. Although there's a caveat for it that if you are finding a gross abnormality and if you are getting even less than 10, then automatically it becomes adequate. Then, sir, you beautifully highlighted that if you have small biopsies, you can often miss out many things. You showed that lymphoid nodule there. I just want to add that if you have a small biopsy, we know that and you're told that subcortical area is usually hypocellular. So if you have a small biopsy, a novice may end up calling it a hypocellular bone marrow, and a wrong level of aplastic anemia may be put. So we need to be very sure that the biopsy is of good length, and the person who is doing it, he should not hesitate to extract a good bone marrow piece, because once you have pierced, you put him under the patient anesthesia, you pierce the cortex, then you can go in and get a good biopsy. Then, sir, for erythroid cells, I also feel that E-cadherin will also be a very important stain, and your comment on that. And over and above, though you focused on bone marrow biopsy, we need to understand that we have to integrate all the information, the clinical features, the bone marrow aspiration, the clot section, and then we should look at the bone marrow biopsy and then integrate everything so that we don't commit a blunder. For example, if you directly see a bone marrow biopsy from a case of megaloblastic anemia, those sometimes it has people have diagnosed it as acute leukemia. So it is very, very important that we need to know the clinical picture, and we need to integrate each and everything and then come to a diagnosis. Thank you very much.
Absolutely. They're all very, very valid points, Professor Tilak. We have an integrated diagnostic meeting every week where all of these specialists who deal with the different aspects of bone marrow interpretation come together, and we produce an integrated diagnostic report for most patients. And this would include, information, the clinical information, peripheral blood findings, bone marrow aspirate findings, what the trephine is showing, what flow cytometry shows, the cytogenetics, the single gene tests, as well as the multiple gene tests, the myeloid gene panels or the NGS that we do. And we've now even started integrating WGS and WS into these integrated diagnostic reports to, give one single combined diagnosis. So yeah, that's really important. E-cadherin is a very, very good erythroid marker, and a lot of people use it because E-cadherin is easily available, largely because of the need for it in breast pathology. The one thing is, the reason I tend not to mention it when I'm doing my bone marrow talks is because of the overlap with multiple other epithelial markers. So when you're trying to evaluate metastatic carcinoma, E-cadherin confuses the picture if you're using it as an erythroid marker. Transferrin is also a really good marker, CD71, and it works very, very well. But from my perspective, alpha hemoglobin is probably the best antibody available because it only picks up the nucleated precursors. So it shows you what you want to see, and you can immediately pick up dyserythropoiesis or erythroid dysplasia by looking at the way alpha hemoglobin is distributed across the biopsy. Do we have any questions? Or it was crystal clear?
No, sir. We do have a few questions. One is how to identify micromegakaryocytes.
Oh, very good question. So the micromegakaryocyte is defined as a megakaryocyte, which is approximately the size of a promyelocyte. It has dense cytoplasm, and it usually has an eccentric, small, round pycnotic nucleus. They are best seen on CD61 or CD42B immunohistochemistry because they come up very, very well. And the important thing to remember is how do you differentiate them from, cutting the edge of a megakaryocyte? Finding one micromegakaryocyte in a biopsy means nothing. Micromegakaryocytes have to be present globally before you can regard them as an unequivocal feature of dysplasia. Okay, so normally when we use them to diagnose MDS, they have to be present globally across the marrow. So, lots of them in the marrow. So just one micromegakaryocyte doesn't make any difference.
Right, sir. So the another question we have is what's the normal count of megakaryocytes in one cavity in an adult?
I generally tend not to count this. Professor Tilak, I think you have a formula for this, don't you?
Sir, it's written in Barbara Bain that you get 7 to 15 megakaryocytes per cubic millimeter. So I tried to do that per cubic millimeter, millimeter into square millimeter. So what I've tried was that, sir, I measured the Trephine biopsy, and then I went through how many megakaryocytes I'm seeing, and then tried to correlate it. Is it coming like that? But I think a better way out is, sir, that a general look would tell you whether the megakaryocytes are adequate in number, increased or reduced. That possibly is a more practical way out, sir.
Yeah. So I don't count megakaryocytes, and over the last 25 years, I've noticed so much variation in megakaryocyte distribution in normal and abnormal that counting really doesn't help. I think I would like to reverse the question. Why do you want to count them? What information does that give you? See, people usually do not ask you whether megakaryocytes are adequate in number. That is done through platelet counts. Okay? So you either have thrombocytosis, you have a normal platelet count, or you're thrombocytopenic. If you've got thrombocytosis, the question is, do you have morphologically abnormal megakaryocytes? And are they increased? If you're thrombocytopenic, people want to know, do you have large numbers of megakaryocytes, which means that you've got ITP? Or do you have smaller or low number of megakaryocytes, which means you're dealing with a hypoplastic, aplastic anemia type of picture, or you're dealing with a hypoplastic MDS? Okay, so that's the way I would approach megakaryocytes, not try to count them, but try to have a general idea of what you expect to see in normal, and then try and determine whether they're dramatically increased or they're dramatically reduced. And that's what Professor Tilak is also trying to tell you.
Yes, fully agree.
Yes, sir. So next we have what causes megakaryocytes to move towards sinusoids?
Causes them. I presume that they are programmed to move to sinusoids, right? Because otherwise platelets wouldn't get into the blood. If you're asking me what gene drives that movement, sorry, I don't know that. But that's a
um,
really interesting question. This is the first time somebody has asked that. Yeah, that's a good point. I think I should look it up.
right. Yes. Sir. Okay. So next we have just a sec, please. Uh, how to differentiate between micromegakaryocyte and dwarf megakaryocyte.
Okay, so just think of what I said. The size of a promyelocyte. Okay, dwarf megakaryocytes are usually bigger, and they usually have much bigger nuclei. Okay, it's very easy to make that distinction. Think of a micromegakaryocyte, double the micromegakaryocyte, and you've got a dwarf megakaryocyte.
Achha, and I just want to add to it that this, okay, while this may be quite academically very interesting, but the settings in which the dwarf megakaryocyte is there and the micro megakaryocyte is totally different. When you talk about dwarf megakaryocyte, the setting would be of CML. And when you're talking about micro megakaryocyte, the setting is of MDS. So, and differentiating them on clinical grounds is very easy.
Yeah, means I was on the verge of saying that we've stopped bothering about dwarf megakaryocytes because we now get biopsies with the clinical details CML. You know, the purpose of the biopsy is very different now, the information that you're giving. So whether they're there or not doesn't make any difference.
Next we have how many megakaryocytes have to be there to call it clustering.
3. So you need at least 3 megakaryocytes before you can call it a cluster.
Then
And that
how
is
to
very logical if you think about it.
next is how to differentiate between leishmania and histoplasmosis on bone marrow biopsy.
That's an interesting question. They look very different, right? So leishmania. Okay, let's talk about, are we talking about HNE or are we talking about, okay, let me start with HNE and then we'll talk about GIMSA. Okay. On HNE, in leishmaniasis, the first thing that you will see is usually erythroid hyperplasia. Okay. And then you'll start seeing these slightly paler patches within the bone marrow where you've started getting collections of macrophages. And the macrophages look foamy, and you can start, when you start doing, fine focusing, you start seeing small bodies within them surrounded by bubbles. Okay. And these bodies are really tiny, and you can have hundreds of these small, tiny little bodies within individual macrophage cytoplasm. And the macrophages tend to be quite large. Okay. Now, when you do a GIMSA stain on this, or if you say do CD1A staining on immunohistochemistry, all of these tiny little bodies pick up GIMSA intensely. They become purple, and you can even see the, the comma-shaped or the small double bits of the kinetophores in leishmania. Okay. Histoplasma, you tend not to see erythroid hyperplasia. You'll see macrophages floating around the bone marrow. And when you look at the macrophages, you start seeing bubbles. You'll see they're foamy, but you'll see individual bubbles. And the bubbles are much larger than a leishmania. You've got the bubbles will start also showing you a central, more dense area within them if you look carefully. GIMSA tends not to be very good with histoplasma. You just get the mucin around the histoplasma picking up. But they are beautifully seen on Grocott. So if you do say a PAS stain, a DPAS stain, or you do a Grocott stain, you see the central fungal spore very well. And so that's the difference. So one size is smaller, size is bigger in histoplasma. You get hundreds of them in a macrophage. You get fewer in histoplasma. The staining pattern is different. The background is different. The other thing that is interesting is you will often find histoplasma within macrophages within blood vessels in the bone marrow. So that's a good place to look for histoplasma because the macrophages circulate and they're present in the sinusoids.
So next we have how to differentiate normal lymphoid aggregate from low-grade lymphoma in older individuals.
Now that's a whole talk, no? I think you'd have to okay, you have to approach this systematically. Okay. So first, if we are dealing only at the level of the bone marrow specimen, I'm not talking of clinical or peripheral blood counts. First, you have to look at the morphology. Okay. Are they lymphoid aggregates? How are they distributed? What do they look like? Okay. Where in the bone marrow are they located? Are they paratrabecular? Are they in the interstitium? Are they in the sinusoids? And then you have to do immunohistochemistry. But before immunohistochemistry, are they small cell? Are they large cell? Then you do immunohistochemistry. Are they B or T? And then you do the same workup that you would do on a lymph node or on peripheral blood to come to the conclusions to try and subtype the lymphomas. Does that
Right.
explain it?
Yes, sir. Actually, it's actually a big topic if you start explaining this
Yeah,
stuff.
normally at bone marrow conferences, we would have entire sessions on this. So
Exactly.
trying to give you a short, succinct answer is difficult.
But so the approach is important, which you actually explained. So next, I guess it's the last one, how to differentiate osteoblast from myeloid series.
Okay. Morphologically, the osteoblasts are pretty well adherent to bone, and you see them. First of all, they're slightly larger than myeloblasts. They're almost double or triple the size. Secondly, they're attached to the bone surface, and even in early osteoblast proliferations, whether they're reactive or whatever, you will see an entire line coating the endosteal surface of the bone marrow of the bone, and they tend to be polygonal. You can actually see the edges. Sometimes you might even see polygons, hexagons, that sort of thing. Cell membranes very, very crisp. They almost look like they're attached to each other. Cytoplasm is abundant, eosinophilic. The Golgi complex is usually huge because they're producing osteoid. Nuclei are large because they have to have a large nucleus because they're protein producing. The chromatin is open and they usually have one nucleolus. Myeloblasts tend to be a little away. They're not sitting intimately adjacent to the bone trabeculae. They're usually singly distributed and they are medium sized rather than large cells. And they often have more than one nucleolus. The other thing about myeloblasts is they often appear to be ovoid rather than perfectly round. So that's a good way of picking them up.
All right, so I guess that will be all. Thank you so much for your time and your expertise. Thank you, Vijay sir, for your insights. And with that, I'd like to end the session today. Thank you so much, everyone.